Module 5, Respiratory. This recording will cover Chapter 24, Coordinating Care for Patients with Infectious Respiratory Disorders. Before we talk about our specific respiratory tract infections, let's just go over a little bit about how these come to be. So one way for these pathogens to be introduced to our respiratory system is via inhalation. They're airborne, they're in the air, they're suspended there, and then here we come, we inhale them in, and they get inside us. There has to be a certain number in order for them to be infectious to us. They have to bypass the trapping of our mucociliary layer in our upper respiratory tract. That is there to trap things from coming in, but somehow they got past that. And then they also somehow avoided our phagocytic cells that are supposed to identify them and destroy them and get them out. So somehow these pathogens have surpassed our defenses. Our first infectious condition we're going to talk about is influenza. So influenza or the flu is highly contagious. We want to make sure these patients are on droplet precautions because that's how it's transmitted. So we want to make sure we're wearing a mask and gloves. So risk factors: age. The very young and the very old are going to be most susceptible because either they have an immature or less active immune system. So we're talking about people younger than 2 years of age and people older the age of 65. Occupation: healthcare workers, so all of us are going to be at higher risk for getting the flu. Family caregivers, or if you work in a daycare or if you work in an elementary school, also higher risk because you come into contact those who are likely to have the flu. Environmental: if you live in close quarters, so in long-term care facilities, in dorms, those kind of places where you're around people for long periods of time, puts you at higher risk. If you have an compromised immune system. Chronic illness like diabetes or renal failure, asthma can put you at higher risk for developing complications. Pregnancy: if you are considering pregnancy, pregnant, or have recently given birth, you're also at greater risk for developing severe viral pneumonia and overall mortality rate, even if you're otherwise healthy. So influenza can be life-threatening. Okay, next are clinical manifestations. So there are a lot of overlapping with the signs and symptoms from the flu and your common cold. So what is the difference? So when you have a cold, the signs and symptoms that overlap are less intense. When you have the flu, they're much more severe. Also, when you get the flu, it is a rapid onset. So one day you're fine, the next morning you wake up and you have a fever, headache, sore throat. It's very abrupt versus the cold where you might start off with like some watery eyes one day and then it develops into congestion and a cough later. That sounds like the common cold. The flu is abrupt with severe signs and symptoms. Okay, so fever, headache, sore throat, severe nasal congestion, cough, malaise, which is muscle aches and pains, malaise, which is not feeling well, and fatigue. When it comes to diagnosing the flu or influenza, a viral culture is really the 100% way to go. However, to get the result from a viral culture, it takes about 10 days. So that's not usually realistic when you have a patient presenting to the emergency room or to the clinic or to their doctor when they're having flu-like symptoms. So normally a rapid influenza diagnostic test will be performed, which is an RIDT, and that usually takes about 30 minutes to get a result. So the negative with this test is that depending on the manufacturer and the type of flu virus strain that's circulating at that time, it is possible that you can get a false negative on your IDT. So with that being said, the provider must obtain a good history and physical on the patient because just because they have a negative flu rapid result doesn't mean that they don't have the flu. So you just want to keep that in mind. Treatment for the flu is going to start with prevention. So we are going to advocate that everyone gets the flu vaccine. Us as healthcare workers, we have to either sign a waiver that you don't want it or you have to get it. So statistically, if you get the flu vaccine, there is a decreased prevalence of the flu. So this is evidence-based. Okay, so I have a picture of eggs here. That is because there are certain types of the flu vaccine that is made from egg protein. So if you have an allergy to eggs, you want to make sure that that vaccine isn't the one with the egg in it. Then I have a picture of a pregnant woman here. So pregnant women, people who are severely immunocompromised over the age of 50 or under the age of 2 should not get the live attenuated flu vaccine. So the live vaccine may actually cause systemic disease like bacteremia to those specific patients. So again, if you're pregnant, severely immunocompromised, over the age of 50 or under the age of 2, you should not have the live vaccine for the flu. So medications for the treatment of the mild flu are really focused on relief of symptoms, so symptom control. So if the patient has a fever, we're going to give antipyretics like acetaminophen. If the patient has muscle aches and pains, we're going to give an analgesic like ibuprofen. And if the patient is presenting early enough with signs and symptoms of the flu, we can give antivirals. So these antivirals, Tamiflu is probably the one you're most familiar with. These are most effective when given within 24 to 48 hours of the onset of flu symptoms. So if you've had the flu for 5 days and then you go to the doctor, these antiviral medications won't be that effective for you. Moving on to nursing interventions. So one of your top priorities when you have a patient that has the flu is going to be isolation precautions. We don't want them infecting us. We don't want them infecting other patients. So that's going to include at minimum a mask and gloves. If there is a risk of getting splashed with bodily fluids, then you may need to put a gown on and eye protection. If the patient needs to leave the room, they should also wear a mask. And if visitors come to visit them, which we should encourage not to, they should wear a mask in the room. If the patient, if there's no option for a private room, because that's the most, we would want them to be in a private room, then it is possible, unless there's absolute confirmation that there's a patient with a similar infection, but that is unlikely. Rule of thumb, they should be in a private room. We want to give humidified supplemental oxygen if needed. That humidified air will improve oxygenation delivery, reverse hypoxia, and they will prevent the drying of that mucosa and avoid other complications. We want to make sure the patient is in semi to high Fowler's position. So when it comes to any respiratory condition, it is very rare that we're going to lay the patient flat on purpose. So with COVID, we were laying patients prone. That is something completely different. When you're thinking about respiratory conditions, think not flat. We want the patient to be semi to high Fowler's. This is going to help with the relief of that nasal drainage. It's going to promote lung expansion. It can prevent atelectasis, and it can prevent aspiration, which can lead to, pneumonia. So that's why it's important to have the correct position on these patients. We're going to administer the ordered medication. That includes what we just talked about, those antipyretics, analgesics. We want to only give those antiviral medications if indicated. We want to make sure the patient has adequate fluid intake. So we know through the lungs via exhalation, we have insensible losses, and that's going to increase with fever and tachypnea. So we want to make sure that they stay hydrated and they don't become dehydrated. We want to provide nutritional intake. So adequate calories are essential for cell recovery. So this patient has an infection. They're going to need those nutrients in order to heal and get well. So frequent meals that are high in protein are recommended. We want to obtain cultures. That includes if it's a nasal swab, throat swab, sputum, even blood cultures in urine before any type of antiviral medications are started. Because if there is some type of bacterial infection, if we start giving those antivirals, it might mask that, and we don't want that. When we teach, we want to practice good hand hygiene, tell the patients and everybody that is at home with them to make sure that they wash their hands. We want to disinfect fomites or inanimate objects frequently because that flu virus can kind of hang out on those items for a while. We want to limit contact with others for up to 10 days after first symptoms appear because that's when they're most infectious. And we want to report the worsening of shortness of breath, change in secretion, so like the amount, the color, the viscosity. So if they're getting like really, really thick and now they're yellow before they were kind of clear, if they have a recurrent fever that goes away, comes back, that's something that should be reported. And then medication teaching. So we want to let them know the side effects, expected and desired side effects. If they are taking an antiviral medication, they need to take all of it. Just like an antibiotic, it's the same concept. They have to finish the whole dose. And antiviral medications do not cure the flu. All it does is shorten the duration and the severity of symptoms. So sometimes when patients know that, then they're more likely to accept and be compliant with the medication regimen. And then we want to encourage patients, of course, to get the flu vaccine every year. We want to prevent them from even getting sick in the first place. Next is pneumonia. So pneumonia affects up to 4 million people a year, so very common. And this is inflammation of the lung parenchyma from bacterial, viral, or fungal infection. So lung parenchyma is made up of lots of alveoli, thin-walled alveoli, which forms a very large surface area in the lungs. So whenever you're dealing with alveoli, you're going to have impaired gas exchange. So anyone who has pneumonia is going to have impaired gas exchange, decreased SpO2, which we'll see on our pulse ox. Okay, really important. If you look at this picture, there's inflammation in the lung, and these alveoli are filled with pus, okay, purulent drainage, and it has bacteria, there's blood cells in there. So those little alveoli are not able to pass oxygen and collect carbon dioxide. So there's going to be impaired gas exchange with any patient that has pneumonia. Okay, so pathogens that cause pneumonia reach the lung in 3 ways. Either we're going to aspirate it, okay, so aspiration of normal flora from our nasopharynx or oropharynx. And a lot of the times the bacteria that's infecting us are normal inhabitants that healthy people live with, okay? Sometimes it's because of poor oral care and we aspirate that, but again, aspiration is a key word here. Inhalation of microbes present in the air, so similar to the flu, we're inhaling something and it's causing infection. And then we have hematogenous, so that means it's coming from inside the body to the lungs. So maybe the patient has a blood infection and then the bacteria in the blood comes in from in the body, makes its way to the lungs, and then we have a pneumonia. Risk factors for pneumonia is going to be recent antibiotic therapy, patients receiving immunosuppressive medications, if patients have been diagnosed with a chronic disease, patients who have been treated in healthcare facilities, like if they've been in dialysis clinic or adult daycare centers or rehab facilities, where they're in frequent close contact with healthcare personnel like us, or to other patients who may be colonized with other infection-causing organisms. Okay, so signs and symptoms. We're going to have all the signs and symptoms that you would have with any infection. So fever, tachypnea, which is increased respiration, shortness of breath, dyspnea, tachycardia, chills, could be productive or non-productive cough, pleuritic chest pain. So pleuritic chest pain is described by sudden, intense, sharp stabbing or burning pain in the chest when you inhale and or exhale. So it's usually exacerbated like when you deep breathe, cough, sneeze, or when you're laughing, that kind of sharp pain, that is called pleuritic pain. In addition, patients will complain of fatigue, myalgia, and arthralgia, so both muscle and joint pain with pneumonia. When the pneumonia is very severe, patients can have purulent or blood-streaked sputum, hypotension, and dysrhythmias. So with pneumonia, we're having impaired gas exchange. So we're going to have to think about those early signs of hypoxia and those late signs of hypoxia because we're dealing with impaired gas exchange. So this list here are validated clinical predictors of increased mortality and morbidity from severe infectious pneumonia. Okay, so that sounds really complicated. What this means is research and studies have shown that if the patient has these items, if they present with these items, they have potential to die faster. That's pretty much what it's saying. Altered mental status. What does that mean? That means there's something going on with oxygen. not enough. So altered mental status. If they're breathing faster than 30 breaths per minute. If they have a systolic blood pressure less than 90. If their heart rate is more than 125. If their body temperature is lower than 95 degrees or higher than 104 degrees. If they have a pH lower than 7.35, which is acidosis. If their sodium is less than 130. If their hematocrit is less than 30%. If they have a PaO2 of less than 60. And if they have presence of pleural effusion, which is fluid collection in the lungs, present on a chest x-ray or CT scan. All of these things equal worsening condition, meaning that this is going to be your priority patient. So not everybody with pneumonia will have these things. Okay, so once the patient starts to have altered mental status and you see these vital signs changing, then that should alert you, red flag, that this patient's condition is worsening. So let's look at the inflammatory response pathway here for pneumonia. Okay, so we have the microbe, the pathogen that enters the respiratory system. So it's going to attract neutrophils. Neutrophils are our first responders. There's going to be a release of those inflammatory mediators, so those cytokines, those little chemical messengers. Then there's going to be an accumulation of exudate, red blood cells, and bacteria. And then two things are going to happen. The little alveoli are going to fill with fluid and debris. We're going to call that consolidation. So when we see consolidation on an X-ray report, that's what they're talking about. That means the alveoli are filled with fluid and debris. And these alveoli should be filled with air because that is where gas exchange takes place. So that's going to be a problem. Another thing that happens is going to be increased production of mucus, which can lead to airway obstruction. Okay, so pneumonia, think those little alveoli are full of fluid, and there's going to be lots of mucus in the airways. So that's what we're concerned about, this consolidation and airway obstruction. Both of these things are going to lead to decreased gas exchange, which is going to be our major patient problem. Once the infection is resolving, macrophages in the alveoli are going to ingest and remove debris. Normal lung tissue will be restored and gas exchange will return to normal, and then you'll have happy lungs. Okay, so that is the pathway. And this is a little picture to help you visualize this. Okay, complications that can happen from pneumonia. You can have necrotizing pneumonia, empyema, which is a collection of purulent fluid or material in the pleural space, which would need to be drained by a chest tube. Bacteremia, which means a bacteria left the lung and went into the blood. Pneumothorax, sepsis, acute respiratory failure, multi-organ failure, and death. So whenever you have a complication that can lead to death, very important we don't let it escalate to that point, and we are picking up cues before a patient gets that severe. So how do we diagnose pneumonia? This is going to be based on a combination of lab results, so blood values, and imaging studies. So we're going to have an increased WBC and a shift to the left. You guys should all know that. That's when we have lots of immature neutrophils, and that's going to tell us there's some type of acute inflammation process going on. We'll have an elevated C-reactive protein, or CRP, which is also a detection of inflammation. It's non-specific. It just means that there's some type of inflammation going on. In early pneumonia, our ABG, we're going to have decreased lowers of carbon dioxide, or CO2, and an increased pH. But as the pneumonia progresses and it becomes late, then we're going to have the opposite. We're going to have an increased CO2, we're going to have a decreased O2, and a decreased pH. Sputum cultures, which take a few days to get the results for, will show the causative or offending organism, so that once we have that organism, then we know what specific antibiotic we can give. So just a reminder, whenever you are treating a patient like this, if they present to the emergency room, you're going to have lots of orders to do, lots of medications, interventions, labs. So you're going to have to prioritize and put them in order. So always remember, if you have an order for antibiotics and an order for cultures, you have to do the cultures first. Okay, always do the cultures first, and then you can start antibiotics. And then of course we have our chest x-ray and CT scan, which may or may not show infiltrates. depending on what stage of the pneumonia it's in. When it comes to treatment of pneumonia, so it's really going to depend on the type of pneumonia, how early they showed signs and symptoms, how early the diagnosis was made, and the overall health of the patient. So if they have a lot going on, then it may be a little more difficult to treat the pneumonia. If the pneumonia is uncomplicated, then the patient can be treated in the outpatient setting, so they can be at home taking their medications. But if the pneumonia is more severe, then it may require hospitalization. And because pneumonia may result in hypoxia, because remember those alveoli are filled with fluid and there's a lot of mucus there, which is going to interfere with gas exchange, we will most likely need to give a supplemental oxygen to reverse or prevent hypoxia. That is usually the first step. So if you have a patient with acute pneumonia in the hospital, they will most likely be on some oxygen. We want to ensure adequate hydration. If you notice, there is a common theme here when it comes to hydration and respiratory conditions. So remember, we lose oxygen, insensible fluid loss when we exhale. So that's one reason. Another reason is to support the patient's cardiovascular status. Okay, so keeping them hydrated will prevent dehydration and hypovolemia. And then hydration also helps with thinning respiratory secretions for easy expectoration. So if you have thick mucus secretions, it's kind of hard to cough those out. But if you're well hydrated, that helps to thin those out so the patient can cough them out more easily. Okay, we can give ordered bronchodilators. That opens up the airways and hopefully promotes easier breathing. We want to implement pulmonary hygiene. So here is what pulmonary hygiene means. Use of an incentive spirometer, coughing and deep breathing, postural drainage, vibration and percussion, and early mobility. So we talked about all of these things except early mobility. So that means activity and early ambulation. So early ambulation, when not contraindicated, is very helpful. The body likes to move. It gets the muscles moving. It gets the lungs expanding. So if a patient can get up, sit up, move around, we want to encourage that. That really helps with breathing. Patient positioning, again, you want to make sure the head of the bed is elevated to at least 30 degrees to prevent aspiration. Side to side turning can help with the alveoli to drain and also to help with maximum ventilation perfusion. And patient teaching, we want to encourage hand hygiene and respiratory etiquette. So that's like when you're coughing and sneezing to cover and proper disposal of like Kleenex tissues that you use in the home. We want to make sure patients are getting adequate rest. Your body needs to combat fatigue and conserve energy. Make sure patients are taking those antibiotics and finishing them all and not stopping when they feel better. We want to ensure proper nutrition and fluid intake. So just like anything, adequate nutrition for healing and recovery, and fluids to help within the secretions so that they can expel those easier. Understanding signs and symptoms of worsening respiratory status. So if the patient is at home with pneumonia and they're having increased hard time breathing, shortness of breath, if they are spitting up blood, stuff like that, then they should seek medical attention. And we want to encourage at-risk patients to get the pneumonia vaccine. So the pneumococcal vaccine over the age of 65, you get it every 10 years. So we do want to encourage that. If the patient is in the hospital, we want to give that prior to discharge. Moving on to tuberculosis or TB. So pathology, Mycobacterium tuberculosis is the culprit organism, and this is transmitted the airborne route through aerosolization. So little tiny little particles in the air float around, we breathe it in, that is TB. Make sure your patient, we have a big sign here, they are on airborne precautions. That's going to be a respirator or N95 plus a negative air pressure room. Okay, So risk factors for TB: low socioeconomic status, immunocompromised, crowded environments, advanced age, recent travel outside the US where TB is more prevalent. And that could be Mexico, Philippines, Vietnam, China, Japan, Eastern Mediterranean countries, a lot of countries. Patients who have substance abuse, and healthcare workers, us, we are at risk. So I want you to take a look at this picture here. It shows 3 lungs. We have latent infection, cavitary tuberculosis, and miliary tuberculosis. So if you happen to be exposed to TB and it comes into your lungs, it does not mean you're going to get TB, because we have an immune system, and our immune system will recognize it. Hey, you're not supposed to be here, engulf it and get rid of it. Okay, most likely that will be the case. Sometimes you inhale it, it plants itself in our lung tissue. Our immune system comes and finds it, and instead of getting rid of it, it kind of seals it off. Okay, so it's kind of encapsulated, and our immune system is keeping it at bay. So we don't have a TB infection, we have a latent infection. So here it is. It is kind of just walled off. It's not going to do any harm sitting there unless we become, immunocompromised and it breaks out of its little encapsulation. Then we have cavitary TB. So here we are, it's starting to spread. So no longer is our immune system keeping it at bay, but it is now active. Miliary tuberculosis is when it invades the rest of the body. So this is a bacteria, just like any other bacteria. We always think of TB being in the lungs, but it can actually spread to different parts of the body. So miliary tuberculosis is when it has entered the bloodstream and it's traveling around to other organs. Okay, so TB is inhaled from people who are coughing or sneezing and have been infected with this bacteria. So these droplets of these M. tuberculosis are very tiny, and they remain suspended in the air for hours at a time. So that is why we have to be really careful, and that's why we put the patients on airborne precautions. So clinical manifestations. So if the patient has latent TB, the patient will be asymptomatic and they will not be infectious. So this means the patient has an intact immune system, and it's going to limit that little tiny M. tuberculosis in the lungs from proliferating and spreading. So as long as that immune system remains intact, that little bacteria is going to remain in that little healed tissue, and it can stay there the whole lifetime, and it may never progress to a TB infection. It's only when the immune system becomes compromised that this bacteria, the tuberculosis disease, can become reactivated. And the most common factors associated with this reactivation would be if the patient has HIV or long-term diabetes or chronic renal disease, if they're on long-term steroids, because we know steroids suppress their immune system, patient becomes septic, or if they are malnourished. So again, latent tuberculosis, asymptomatic, not infectious, but they do have the bacteria in their lungs. It's just kind of walled off by our immune system. Then we have a symptomatic TB infection. So that's going to be referred to as primary progressive TB infection, or PPTBI. So this develops in a very small percentage of people who have been exposed to the bacteria. Initially, the symptoms are going to be kind of non-specific, so maybe like fatigue and some weight loss and night sweats. A cough will develop eventually, and then you will have a rusty colored sputum, which means there's blood in it, so blood streaked or rusty colored sputum. And then as the disease progresses, the shortness of breath, the orthopnea, and rales, which is what you'll hear with your stethoscope, will become more and more prevalent. So how do we diagnose tuberculosis? So tuberculosis is a bacteria, so we can get a sputum sample and culture it. That takes a few days to get the result. We can do a PPD test like pictured here. That's a purified protein derivative skin test, also known as the MAN2 test. We can do chest x-ray to look for lung changes. We can do a nucleic acid amplification test, or NAAT. That's the most rapid and accurate screening for TB, and it tests respiratory secretions. There's also a blood test, quantiferon TB Gold, and that can show infection, whether it's active or latent. And usually you can get that blood test result within about 24 hours. Okay, so let's go back to the PPD testing. So before you perform this test, you want to ask the patient if they've ever had a positive PPD in the past, because you don't want to do it if they have. You want to do another option here. And you also want to ask them if they've had the BCG vaccine within the last 10 years. BCG vaccine is a vaccine for TB given in other countries. We don't administer that here. So if they've had it within the last 10 years, then that can result in a false positive MAN2 test. So for this, you would want to do like the quantiferon TB Gold test, not a PPD test. Okay, so the way you do it, you're going to get an intradermal needle. You're going to inject the solution, and then the patient needs to come back to have that read within 48 to 72 hours. This is a delayed hypersensitivity reaction, so that's why we have to wait at least 48 hours to get that read. When you're reading this, you're looking for induration. So induration is not erythema, it's not redness, it is palpable, so you can feel it. It's raised and it's hardened. So you can have, like this picture here in the middle, a red area, but if it's soft and flat and you can't really feel anything, it just feels like all the skin around it, then that's a negative result. And if you do have induration and it's more than 10 millimeters, then you're considered to be positive, a positive PPD test. If you're immunocompromised and it's 5 millimeters, at least 5 millimeters, then that's also means you're positive. So what this means is that the patient has developed an immune response to TB. It doesn't mean that the patient is actively infectious. It just means that they do have it. They've been exposed and the body has had an immune response to TB. So this means further investigation is required. Okay, so interventions and assessments we want to provide for a patient with tuberculosis. Humidified oxygen. So humidified oxygen helps to make sure that there's adequate oxygen delivery to the tissues. And then, of course, it maintains the integrity of our mucous membranes so it doesn't dry them out. We want to make sure that we're monitoring oxygen saturation because it may decline if the lung tissue, if the condition is worsening. Airborne isolation, the patient should be on isolation if TB is suspected. So airborne is going to be an N95 mask or respirator and a negative pressure room. Temperature, we are going to anticipate that they may have a fever because they have an infection and that's part of the inflammatory process. So an elevated temperature is not necessarily reportable to the provider. Sputum, their sputum might be blood tinged or sometimes referred to as rusty colored sputum. So that happens, we will see that when there is destruction of that lung parenchyma tissue. And then here on the slide, I wrote sputum times 3 on different days. So when we are trying to see if the patient still has that bacteria in their sputum, we will send a sputum sample once every day on 3 different days in order to get an accurate reading. And preferably we like to collect sputum first thing in the morning. Breath sounds, we may hear wheezing, and that will be a result of those irritated airways. And then if the patient has fluid and exudate, then we'll hear rhonchi from those secretions. If a patient has tuberculosis, they are going to be on antibiotics 100%. That is the treatment for TB, and it is essential to control the spread of disease in the hospital setting and in the outpatient setting. Adequate nutrition, we want to make sure the patient has enough calories to maintain their body weight because those are the ingredients we need to recover during that recovery period. A lot of times when they have lost weight before diagnosis, we want to bring them back up to their baseline. When it comes to medications, these patients are going to be on oral medications for 9 to 12 months, so it could be a whole year. And these medications will begin while they're in the hospital. So the 4 medications that are used are isoniazid, rifampin, pyrazinamide, and ethambutol. So these medications are potent, and 3 out of 4 of them are hepatotoxic. So we want to keep an eye on those labs for the liver. Patients should stay away from other hepatotoxic medications like acetaminophen and alcohol. So that's education for your patient. Because these medications have to be taken for such a long period of time, it's important that these patients follow up regularly and they have some sort of support system, either from family or in the community. So a lot of times these type of patients will be enrolled into community programs where a nurse will come to the patient's house every day to make sure they take their medications, where they will witness the patient swallow those medications. It is so important because if they don't, if they're not compliant, then one, the tuberculosis can become resistant to these antibiotics, and we don't want more resistant bacteria in our community. Number two, they're not going to get rid of this infection, so they're likely to spread it around and the cycle will just continue. So very, very important part of this is teaching to make sure these patients are taking their medication and they're following up with their doctor, and they come in to get those sputum samples every so often as directed by their provider. And complications that can come from TB are respiratory failure, because remember, this bacteria can eventually travel throughout the whole body. It doesn't happen to everybody, but it can happen, especially if you're immunocompromised. So it can end up in the brain as meningitis. It can end up in your lymphatic system, in your bones, and you can end up in liver and kidney failure. So all bad things that we don't want to happen. So the focus here is controlling transmission. We don't want it to spread around, and we want to make sure they take their meds. Okay, and that concludes this chapter.